Now we come to the last presentation. This is a joint presentation of Stefan Konijnenberg and Nicky van Melick. Stefan Konijnenberg is general practitioner and specialized in ultrasound and orthopedics, and Nicky van Melick is physical therapist and movement scientist and sports physical therapist. And they will give a joint presentation on the guideline on traumatic knee injury.
Thank you. Thank you for this introduction, and it's great to be here, I think. And we will do it a little bit different today because we give our presentation with the two of us together, just to let you see how we work together in first line, so physical therapist and general practitioner. I need that one. We have already been introduced, so first, what I want to tell you is that we have two guidelines here in Holland. We have a guideline for physical therapy. That's not that old. It's from 2015. And we have a guideline for general practitioners, and that's already, I think it's 8 years old already, and it's being revised at this moment. We are both in the working group of that guideline, so I think we both exactly know what we will do in the new guideline. And what we will tell you today is with a case of a patient. So I'm not going to tell you exactly what is in the guidelines. We will just show you how we work together based on what's in the guideline. And the case is a 40-year-old cyclist. And he fell in yesterday's training and he had an acute knee injury. And then he came to me, because in Holland it's possible that a patient directly comes to the physical therapist. And what I see when he comes in, he walks on crutches. He has a lot of pain in his knee, he has a swollen knee, there's a lot of knee effusion. And he has pain with active knee extension and flexion. But I think that is the case in all acute knee patients. And when I see that patient, the first thing we do is a patient history taking. We want to know what happened exactly. What was his trauma? Was it a contact trauma? Was it a non-contact trauma? What did he do? Was there pain? Was there immediate pain, or maybe pain came later after trauma? Was there a popping sound, especially for ACL injuries? Was there effusion, and was the effusion immediate, or maybe just after a few hours, or maybe a day later? Is there any giving way? So the patient tells you, when I walk and I have to turn, I feel like my knee is giving way. That's important to know because of ligament injuries. Is there any locking? Is it true locking? And does he have pain during his daily activities? In this case, this patient was a military, so he needed his knee in every day. When I had completed the history taking, I went into the patient examination, and this is what I found. I found a grade 3 effusion, so a very swollen knee, a range of motion of only 80 degrees of flexion until 0 degrees of extension. The joint line tenderness was positive on the medial side of the knee, but I think that applies to all acute knee injuries, that joint line tenderness is positive. There was a positive Lachman, but I used a question mark, and I will show you in some movies later on why there is a question mark in there. A positive valgus stress test and a positive posterior drawer test. So when you see this, it seems like there is a lot of injury in this knee. And I will show you some movies from this patient. This is the Lachman. And it's his left knee that's injured. And when you take a look at these movies, you will think there's a positive Lachman. But when you take a closer look, you will see that when I start my movement, the knee is already a little bit more posterior than the other one. So it might seem like there's a positive Lachman test, but it's not. And I will explain later on when I talk about the PCL. This is the valgus stress test. So remember, that one is his injured knee. And you can see on the right knee there's also some movement, but that's normal. We want to compare the left and the right knee, and you see that on the right knee there's a lot more instability. So this accounts for MCL injury. And then the posterior drawer test. You can see it's positive. And that's why we thought there was a positive Lachman, because the tibia was already a little bit more posterior. I will show it again in the Lachman. Can you see it? When I start moving, the tibia has already fallen to the posterior side. So that's why it seemed like it was positive, but it was not. So what does our guideline tell us? When there's an MCL injury, we as a physical therapist need to refer to the orthopedic surgeon, but that's not something I can do. I need the GP to refer to the orthopedic surgeon. But it's important, and Stefan will tell a lot more about that immediately. For the ACL injury, I think it's also important to see an orthopedic surgeon to talk about the options. Do I need a conservative treatment? Do I need operative treatment? But it doesn't need to be there in a few weeks. You can delay it and just start your physical therapy treatment. I didn't tell anything about the PCL injury in here, but I think the most important thing is that we need to remember this one. The MCL injury is a reason to refer to the orthopedic surgeon immediately. So what I do when I see this patient, I cannot refer him, so I contact Stefan by phone or mail, and he will tell what he will do.
Yeah, thank you. So what can we do as a general practitioner? Well, normally we know our patients, so we can ask them what's the problem of your work, on your daily functioning. But we also know what were the previous complaints and traumas of the knee, of other joints. We can look after a previous X-ray examination, and we know about the current medication, and some of the medications are very important if they use antibiotics or anticoagulants. But you also know everything about the comorbidity. Is there diabetic? Do we have heart complaints, or is there another problem in autoimmune immune diseases? Sometimes very important to look at family history, because we see sometimes that in one family there are a lot of ACL problems. Allergy is important. And in Holland, it's possible to refer to hospitals, but you can also refer to other private clinics. So we have to be sure where we are referred to. We look at the patient. Of course, we have all the descriptions Nikki gave me, but we look at it, and according to the guidelines, we do some of movement research, not very much, because there is not much evidence in the first line of all the tests there are. The only test, when you have a Thessaly and a McMurray negative test, then you're pretty sure you don't have any meniscus problem. But all the other tests, like the Epley and the McMurray, are not that very good. And we have the Ottawa Neal rules to see if there is some evidence of fracture. But X-ray, we don't do that much in the first line. Only when you think, well, we have an acute problem and I think it's a fracture. MRI, we don't do that in the first line, because there is no evidence that MRI in the first line is cost effective. So there is very poor evidence to do more investigation than the physiotherapist did already. What's not in the guideline, and the guidelines are always are always a little bit old. There are possibilities in the first line and in the second line, but also with physiotherapists to do ultrasound to see. And things are changing. It's not in the guideline, and it will not be in the guideline in the coming year, but surely after 10 years. An ultrasound changed. You can see the ACL. You can see what's the problem with the MCL. You can make stress ultrasounds to see if there is some problem there. You can see the difference in the widening of the joint space. You can make a video of it, and you do the same investigation as you do as physiotherapists, but then you do it on ultrasound, and you see the problem there already. And you can see in this case the PCL, and you see that's a normal PCL, and this is the PCL of a torn knee with problems. So things are changing, but it's not in the guideline. In the guideline, we have a few exceptions to directly refer to the orthopedics. That's the fracture, the knee locking, and the MCL. And there are some problems more, of course. And we know we don't have to rush because we know it doesn't make much difference to wait some weeks. But of course, it's important which patients are sitting for you. In the guidelines, we say when you have functional instability, then you have to refer patelloluxation with severe problems, a meniscal injury. But how do you know that? And when do you know that? And what's the time frame? Is it within a week? Is it within 2 months? We know that the MCL injury, that you can better refer that quickly to the orthopedic surgeon to get a brace. You could give a brace in the first line, but it's very difficult to do that because of the insurance. MRI, we don't do that in the first line. Maybe the orthopedic surgeon need to do that. Or in my case, we do that with ultrasound. And then you can discuss when you do the HCL reconstruction, if it's necessary or not. But it costs some time to refer them to the orthopedic surgeon. So I phone Nicky back and I say, yeah, I'm agree with what you found, and I'm agree with that. We have to refer this patient to the orthopedic surgeon. But now you are again.
Okay, so this is great. I sent him to Stefan, and Stefan is sending him back to me to do some physical therapy in the pre-operative phase in this case. Is it an ACL reconstruction? Will there be a PCL reconstruction? I think that's what the surgeon and the patient have to decide together based on what he wants to do afterwards. But okay, he got the brace for the MCL injury and he's referred back to me. And the great thing about the MCL brace, it's that hinged brace, but it's full range of motion. So we can do almost everything with the brace on. He has to wear it for 6 weeks, 24 hours a day, but we can do physical therapy with the brace. And I guess this counts for almost all acute knee injuries. That the first goals you have to reach are that there is a full extension of the knee with an optimal flexion, and there can be some discussion about what is optimal. I think you should consider what the patient wants to do when it's optimal for that patient. There should be a minimal knee effusion, and you should have an active dynamic gait pattern. And those 3 are, in my opinion, the first goals you need to reach with your physical therapy treatment, with every acute knee injury, whether he is conservative or pre-operative. So that's really important. And what I see a lot is that a lot of patients don't have, for instance, full knee extension when they have surgery. And we discussed about this before our presentation. What we told each other is that we hear a lot that patients get the advice to use a pillow under the knee. And the pillow makes sure you will never reach that full extension. So that's the first thing I always say to them. Do you use a pillow? Don't do it. Just fully flex your knee. If it's painful, it will be better. And maybe we need to do some passive mobilization, but in the most cases, the patient can do it himself. Another thing I see a lot is that patients have a knee effusion, grade 2 or 3, and do strength training. In my opinion, it's impossible to do strength training when you have a grade 2 or 3 knee effusion, because the effusion makes sure your quads don't work, and you want to train. I think it's pretty impossible. So make sure the effusion is only grade 1 or less, and then start your strength training. And what's important, and that's in the case of ACL reconstruction, it's also proven in some research articles that the quad strength needs to be 20%, at most 20% deficit from the other side. Because if you don't reach that LSI of 20% or 80% in this case, the post-operative treatment will take longer. So this promotes that we need to do some physical therapy in the case of an acute knee injury. And it's great that in our case we can work together and the general practitioner refers the patient back to me to do this. So the most important things we want to take you home is that the collaboration between GP and physical therapy is really important. And I think it's always also true for guideline development. We need to work together also with the orthopedic surgeon to develop guidelines. And the most important thing we think from this talk is that the MCL grade 2 or 3 injuries need bracing within 2 weeks after injury. The brace needs to be worn for 6 weeks. And you can just do physical therapy with that brace on. Okay, thank you so much.
Thank you very much for your presentation. Are there any questions? I have a question because you showed an excellent example of a clinical cooperation, but can you explain how the development of guidelines contributed to this clinical success?
Well, I think what changed is that when we make a new guideline, we invite all the people who's working with those such problems like a knee to give a response. And so in this case, Nikki is one of the panel, the board members of the guideline. So we can learn from each other, but we also can think about what are you doing, what are we doing, and how can we make that in one line? Because I think the problems of guidelines is when you are not close together, I think you always create a problem.
Thank you. Did any questions came while you were thinking? Yes?
Thank you very much. Very interesting case. I was wondering, you were talking about the deficit of 20%. What about, in my experience, it really does matter the dexterity of the limb. So usually people have one leg stronger than the other, and this might be up to 15%. So it does matter if the injured limb is a dominant or a non-dominant, because then you have a very different deficit. You see very different deficit. And this is more of a comment, but my second question is, you said that you shouldn't exercise with the effusion grade 2 or 3. So do you use any disinhibitory techniques like putting TENS or cryo during exercise or combining it with the neuromuscular stimulation? Because in my opinion, you have to activate muscle as soon as possible, not wait for effusion to resolve, because it can take a while.
Thank you for your questions. I will start with the last one. I think it's a normal process for a knee to have an effusion for about 3 to 4 weeks after an acute knee injury, because that's just the wound healing of the capsule. And I do not do anything in those 3 to 4 weeks to speed up that process. It will come naturally. When it doesn't, when I think there's a delayed recovery of the effusion, then I will use, but then I contact the GP, maybe something like pain medication or NSAIDs to stimulate that process. But I do not use the techniques you named up. And then the first question about the dexterity. That's a really good question. And it's something we are investigating right now, what the influence is of the dominant leg that gets injured or the non-dominant leg. And I think opinions are divided. Some people say it does matter. Some people say it doesn't matter. I think it does. So I agree with what you say. But we don't know what is a normal variation between legs. And that's the first problem we need to resolve. Thank you.
I had a question about the development because I saw that there's an evidence-based statement and a general practitioner guideline. Did you come across any discrepancies? Because what Wilfred and Astrid showed were two guidelines on the same topic, and I was involved in both. And then I saw that, for example, for the literature review, slightly different methods were employed. Which can lead to slightly different conclusions. What is your experience with that?
I will give a short answer. I've been involved in both guidelines, also in the physical therapy guideline. The biggest difference between the both guidelines, in my opinion, is that for the GPs, the literature search is only in first line. So in physical therapy, I think we take some bigger steps and also include literature from second line. Maybe you can say something?
No, you gave the answer.
Okay. Well, if there are no other questions from the audience, I think we can close the session, but not before thanking all the speakers in this session, because I think they gave an excellent number of examples from multidisciplinary collaboration in guideline development. Thank you, and I wish you a nice closing session of this Congress. Thank you.